Good evening, all. Good evening, respected delegates. And I welcome you on behalf of InnovoCare Health Hub Solution and Geriatric Society of India Eastern Zonal Branch. Today, we are going to have a very important virtual med talk that is on importance of medication adherence in long-term care, in long-term elderly care. So we are really delighted to have with us as chairperson, Dr. Kaushik Ranjan Das, who is formerly president of Geriatric Society of India, and he is also a consultant geriatrician at Kolkata. So welcome, sir. Also, we are privileged to have with us Professor Shantanu Kumar Tripathi, a very noted clinical pharmacologist in this country. Currently, sir is the principal at JIMS, JIMSH Hospital, Boj. So welcome, sir. And we are really happy and proud to have with us Professor Proshun Chatterjee, who needs no introduction in the field of internal medicine and geriatric medicine. He is the perfect combination of clinician and clinical researcher. Currently, sir is the head of Department of Geriatrics at AIMS, New Delhi. So, sir will give us the lecture, the theme lecture on importance of medication adherence in long-term elderly care. So, welcome, sir. So, today, as we are going to understand the importance of medication adherence as a student, as a learner in the field of medicine, clinical pharmacology, what I personally believe that when we talk about prescription, that is not only a piece of paper, that is something beyond the piece of paper. This is the connection between prescriber or physician and the patient. So prescription, that P, that actually is a communication between another two P, that is prescriber and patient. So when we talk about this prescription, especially in elderly care, we always want that whatever instruction in the prescription we give, that should be followed by our patient. And as we are talking, as myself, a student of clinical pharmacology, what I learned that a very important perspective of clinical pharmacology in promoting safe patient care is using principles of clinical pharmacological reconciliation, review, and feedback for every patient. And one of the very key objective on that CPRRF is maintaining or ensuring medication adherence. I think all of us know that when we talk about medication adherence, this is defined by WHO as the degree to which person's behavior corresponds with the agreed recommendation from a healthcare provider. Maybe this definition is a little bit clumsy or difficult to understand, but again, if we want to emphasize on the word A of adherence, we need to tell ourselves that A means we need active participation of the patient into our therapy. So it is not a one-way dictation. It is not a one-way story. It is a bi-directional thing. So we need to involve our patient into this treatment procedure so that they can understand it, they can believe it, they can have the confidence on that particular prescription. And that is why I think yeah. So that is why what we learn that we need to follow some simple rule to ensure adherence. And in that simple, the acronym that suggests the regimen should be very much simple. So simple regimen. I for impart knowledge. So we need to have an informed prescribing, aim for modify the patient beliefs and human behavior. P for provide communication and trust. L for leave the bias. E for evaluate adherence. So when we talk about provide communication and trust, it is very important to improve our own communication skill. And when we talk about leave the bias, that means sometimes we need to understand the physician interventions that increase this partnership between patient and physician, and those strategies like encouragement to the patient to learn about their own disease, sometimes some demographics, easy demographics information, some communication already available in the internet, and that should be a valid source. This need to be spread towards our patient. And finally, again, we need to evaluate the adherence, whether I am doing the right thing or not. We need to evaluate. So prescription, communication, whatever we are telling, it is not just a snapshot. It should be, we think about something called as, when we do clinical research, when our design becomes ambidextrous, just like prescription is something which should have an ambidextrous relationship with me, the prescriber, and the patient. That we need to remember. What is that ambidextrous means? When we talk about prescription, we first need to understand what is the patient's thought process. What was the medication he was taking? And then we need to follow up the patient carefully to ensure the adherence. So finally, make it little bit, if we want to make that simple acronym simplistically to us, the message should be, the mantra should be, the regimen should be simplified, educate clearly, education should be proper. We need to address the patient concerns, build the trust, avoid bias, and regular check the adherence. And we are really thankful. Very recently, we got one news from Journal of Diabetology, which is a very good impact factor journal. One of our clinical randomized clinical trial, randomized controlled clinical trial had been accepted, where we use 4-arm. So that was a factorial design clinical trial, where we use in 1-arm, the standard of care was only provided. 1-arm, we provided only the clinical pharmacological reconciliation review and feedback principles. 1-arm, we give one device that today also we will discuss, the MedpeR. And another arm, we use together CPRRF and this MedpeR device. And what we found, there was a statistically significant better adherence after 6 months in the arm where both CPRRF and the device being utilized. So I think this is really a big story for us also. And again, we are really happy to have with us our chairpersons, Dr. Kaushik Ranjan Das and Professor Shantanu Kumar Tripathi. I request them to introduce this topic and let all of us learn from Professor Proshun Chatterjee. Over to Dr. Kaushik Ranjan Das and Professor Shantanu Tripathi.
Thank you, Dr. Shambhu. I am very happy to be a supporter of today's program being organized by MedpeR Health Solution on a very important issue, that is adherence to medication in long-term care in the elderly. There is a special deliberation on the matter, and speaker is none other than Dr. Prasun Chatterjee. He is also a great academician and also involved in geriatrics for many years. I feel proud of him. And Dr. Shambhu Shamadar will also demonstrate the device that has been innovated by Rohan Tripathi and his team. So actually, adherence to medication in elderly is a very important matter regarding the quality of life, morbidity, mortality also. So we shall learn different aspects of that from our learned speaker, Dr. Prasun Chatterjee. I wish all participants will be benefited from his lecture, and also all delegates will be benefited from looking at the deliberation on the MedpeR, that is the device. I wish great success of the program. So over to Tripathi sir, Shantanu Tripathi sir.
Thank you very much, Dr. Das. It's a pleasure to have this evening Galaxy's Dr. Das, who has spearheaded the geriatric care movement in the country. There are many other stalwarts, but we are fortunate to be associated with Dr. Das and GSI for the last 6-7 years. And this is really an important area today we are going to consider. And I thank Dr. Shambhu, who has very nicely introduced the topic. And then we are also waiting to hear learned Dr. Chatterjee, who will be also sharing us his thoughts and his experiences on this theme of this today's lecture. There are certain catch points here. One is, of course, the adherence is important for everybody, but here we are going to discuss how important is it in the elderly and why we are talking about this, and that too again in the long-term care. That means otherwise stable chronic diseases for which the elderly person is trying to adhere to the different prescriptions. As we know that elderly person is more vulnerable to suffer from multiple comorbidities, multimorbidity, and for each of these days we are inclined to visit specialists, and it is likely that the same person, same old man, is trying to actually adhere to 4 or 5 prescriptions simultaneously. End of the day, he is trying to actually consume some 12 or 15 or more than that number of medicines. So sometimes it becomes really difficult. So I was just thinking that why things are complex in elderly population particularly. One is, of course, polypharmacy is rather a rule than an exception in most of the elderly above 65. A good proportion of elderly people, they will be actually rationally requiring multiple medicines. The more the number of medicines, the more is the chance of adverse drug experiences. The more the chance of adverse drug experience, more is the chance of lack of adherence, apart from, of course, the physiological forgetfulness, which has a direct association with the age. So at the same time, the other thing that would come, that is about the scope and need for de-prescribing. And as Dr. Shambhu has rightly mentioned about clinical pharmacological reconciliation, review and feedback, that will give the opportunity to really critically review the prescriptions and the necessity one of the greatest problem is because of the lack of family physician concept. We do not have family physicians these days, general practitioners these days. So it becomes very difficult to coordinate from the patient's perspective. So most of the time, many a times when the old man is visiting a particular consultant, he is looking from his own window instead of taking a holistic view from the patient's perspectives. Okay, so thereby there is also chance of repetition. Same drug with different brand names. We have also come across such experiences in some of our studies, that the same medicine, like one of the common example is proton pump inhibitor. The patient is receiving the same pantoprazole with three brand names given by three different specialist physicians. So that is also a possibility. We should keep that in mind. The so far as the technology support to improve adherence, that is actually probably can only look after the forgetfulness part. If the old man is otherwise finding it difficult to remember or recall taking the medicines in the right time, that can be addressed by the device or the tool, possibly the kind of tool that is going to be discussed today. But it is much more complex a thing. It is not just forgetfulness, there are other issues also. But then it is good that gradually in the last say 5-7 years or 10 years we are giving more attention to these areas and understanding this is a significant importance. And hopefully elderly care is likely, we are expecting elderly care is going to be of better quality in years to come. Without standing further between our speaker, Dr. Chatterjee, and the uh, participants, I would rather end my talk here, and I would request Dr. Shambo to take over and welcoming our learned speaker, Dr. Chatterjee, to come up. Over to Dr. Shambo.
Yeah, it is a real pleasure of us to invite Professor Proshun Chatterjee. Professor Proshun Chatterjee, currently the head at the Department of Geriatric Medicine at AIIMS, New Delhi. So welcome, sir. Now this stage is yours.
Thank you, Dr. Sambu, and thanks to Chairperson. So I need to share the screen. Can you see the screen?
Yes. It's coming.
So
can you make it full screen, sir?
I made it. Is this full screen or I'm not sure?
No, not it. It is not full screen. Yeah, below there is an option. You can click on that.
This one, na?
Yeah.
Now, this is okay.
It is not coming. So one thing you can do, you just unshare the screen and again reshare. There will be an option you can select. No. It is not now full screen.
Now
You
it's full screen.
You just click on the first slide.
Can I, Mr. Shambhu or Dr. Shambhu, can I interfere?
Yes.
If Dr. Prashan click on the slideshow, he will click on the slideshow.
That is I am telling.
Then we'll click on from the beginning. Then it will be full screen.
So I did that.
Oh, you have done.
No, you make it in your screen. It is full screen, na?
Yes.
So just do not do anything. Just stop your screen share in the Zoom. There is an option stop screen share. In the Zoom, don't make it, that is, stop your full screen share. Yeah. Now again start sharing.
Now is this full?
No. No, while stops screen sharing, you should not minimize that full screen PPT. Make your PPT in full screen mode. From Zoom only, you have to just unshare.
Okay, let's do that. From Zoom only, I have to share. Is this okay? I think we can start.
Yeah, it is
Noth-
not okay, but then you can go
noth-
ahead.
Yeah,
Doesn't
nothing
matter.
much to,
Doesn't matter.
nothing much to show. Uh, so if I make, if I am clicking in slides, so what is the problem? What can you see anything or you are not seeing anything?
Not seeing anything. So if you don't, then click on the
So let me keep it like this.
make it, yeah. Now, now it is okay. You can carry on.
Okay. So thank you, thank you, Sambhu, thank you, Dr. Tripathi, and thank you, Dr. Das, for giving me this opportunity. The day Dr. Tripathi called me, I told, honestly speaking, this is not my expertise, to be very honest. I work with primarily dementia and longevity. These two are my area of interest. But still, I think I'll try to say something. Most of the things have already been discussed by Dr. Sambhu and the chairperson. Um, uh, so this is the picture of our national center. This is the exclusive center for caring elderly people who are 65 plus here. We have this building is 9-floor building, and we have everything under one roof. I have already started geriatric neurology, geriatric oncology here in this building. We have ICU and other facility, and this is the place where I'm associated with one not-for-profit organization called Healthy Aging India. So I like this NGO, and I'm also actively participating in weekend for caring elderly people who are helpless, whose children are not taking care of them. So this is you can say this is one form of long-term care setup. So my experience is very real-time experience with them. You can say that way. So definition already someone has mentioned. Simple in simple language, whatever we have prescribed, if they can follow it properly, that is the adherence we are talking. This is one of the most important factors that determine the outcome. Especially the patient suffering from chronic illness. For elderly, we called it is multimorbidity. Multimorbidity means those who are not aware here. More than two or more is multimorbidity. So it's like even nowadays we are getting even if 45 plus you see start seeing them, they have also multimorbidity. So invariably someone who is 60 plus, 65 plus or 70 plus, they will invariably having multimorbidity. And geriatric syndrome. Geriatric syndrome is fall, frailty, dementia, sleep problem, then urinary incontinence, etc. So they have multiple problem. They have geriatric specific issue we called as geriatric syndrome. So for obvious reason, geriatric medicine is still not that popular branch. So seniors they just visit the organ specific specialist, sometimes internist, but mostly they prefer to go to organ specialist, organ specific specialist. As rightly one of the chairperson mentioned, that they'll end up with multiple drugs. So primary job in AIMS, what I do is they come to me with around 20 medicine from multiple specialists. Then I try to find out what is the essential and minimum drug I can prescribe for someone who is especially 75 plus. And I try to write it very clearly that Babuji ya Mataji, you have to take this 5 or 6 drugs, which is vital for your life. And one of my very favorite medicine professor, Professor Sanjay Chatterjee, he used to teach us that, Dr. Prasoon, you must know the side effect of the drug before you prescribe the drug. So I always try to explain my patient what are the side effects of the drug before explaining the effect of the drug. That always help them because side effects are plenty, and if you don't explain, that is one of the major reason they stop the drug. That doctor, I had this problem, I had a little bit of dizziness, I was feeling too sleepy. I was not feeling well, so I stopped the drug. And they never ask you second time because they don't have the opportunity to ask me. Usually my patient come here 3 monthly, and for most of the doctor as like that. So adherence to treatment is the key link between treatment and outcome. And so whatever you consider, ultimately we treat as a physician, our role is to treat with medication. So in the key component is correct dosage, correct time, consistency. So consistency is here just like compounding. हम जैसे SIP, we talk about SIP. So most of the drug, because most of you are here pharmacologists, so you know much better than me. So it has compounding effect. So until unless we are not working on that, ultimately, especially chronic non-communicable disease, it will not have that impact. So these are the factors that will also be influenced by somebody's lifestyle, diet, behavioral changes, and the external influences where he or she is living. That is very, very important. If you see, I'm not very sure, but yes, during COVID crisis, after COVID crisis, we did a study of various old age homes and long-term care setup of across the country. With the help of WHO, that includes even few facilities of West Bengal. The scenario is almost same in most of the places where it is not very highly paid for lower middle class, or someone who is financially not that strong. For them, staying just
No, তাই এখানে রাখলাম
so just staying it's like they're just living. They just want to die there. They as if they're reaching to old age home to die. Something like that. The approach is not at all very positive. So that also matters for your medication adherence. Regarding prevalence, the data is primarily from Western country, but even in Western country where we think that people are very educated, people explain them very well. But in them also, nearing 50% elderly people do not take their medication, especially when they are staying in long-term care. There we call as nursing home. So in nursing home population of Western, for Western elderly, even them also around 50% elderly do not adhere to the prescribed medication. So one of the reason, what one of my previous speaker very rightly mentioned, is over medication, polypharmacy, and of course drug side effect, which has not been explained adequately. So other factors is physical limitation. These are all pictures of from our old age home where we try to keep them healthy and happy. So it can be visual impairment, which is one of the, again, visual impairment is one of the geriatric syndrome, which is many a times unnoticed, untreated. Even if cataract is not adequately treated, still till date in this country for elderly people. So visual impairment matters for your medication adherence. Then your reduced mobility, hearing impairment, swallowing difficulty, and very, very importantly, cognitive challenges has a huge impact on medication adherence. So you can easily understand someone who has cognitive impairment. He he's not only forgetful, whether he has taken, because earlier stage of cognitive impairment is recent memory impairment. So whether they have taken the medicine or not, so sometimes they take it, they do overdosing, sometimes underdosing. So anyway, that is not going to add, the medication is not going to adhere until unless they have informed caregiver with them who are taking the charge. And one more manifestation in cognitive impairment, once the disease progress a little bit, they become agitated, they are reluctant to take medication, and a good number of cognitive impairment patient in their early stage, they have huge amount of anxiety, and because losing your memory is a very, very depressing phenomenon at the very initial stage when they have still their inside intact. That time also we have noticed they try to skip medicine. They say क्या हो जाएगा medicine लेके, मेरा memory तो वापस नहीं आएगा, something like that. So there are financial constraints also in the country like India, lack of social support, transportation issue, health illiteracy. Why should I take this medicine is also very, very important. So consequences of poor adherence, we all of us are aware of that. Worsening health condition, increase in morbidity, higher hospitalization rate, reduced quality of life. Incorrect adherence causes complications from drug-drug interaction and increased burden on caregiver. Recently, I saw a patient who got admitted in our private ward. He was staying in old age home. So his next colleague was suffering from late onset rheumatoid arthritis. So he has been prescribed methotrexate, but for him it was for fever only paracetamol. But he took daily methotrexate from the next person because the caregiver didn't explain them, and the person has a little bit of visual impairment, so he cannot read whatever the prescription has been, whatever medicine has been was there next to his table, he was consuming that. So he came to us with pancytopenia, one of the side effect of methotrexate toxicity. Fortunately, he survived because he came in right time, and we supported with GMCSF and all these things. So this is one of the very common example I recently gone through. So role of healthcare providers, the point is geriatric medicine is definitely multidisciplinary. It ranges from the patient care coordinator who helped in our hospital. We have patient care coordinator who help the person to for the registration. And when you leave the hospital, again, you meet him or her and leave when he again brief the person that these are the medication which has been given. In the midway, there is doctor who initially there is assessor, which is a nurse, where we do a comprehensive geriatric assessment, especially ICO, intrinsic capacity assessment, ranging from vision, hearing, mood, cognition, mobility, and nutrition, followed by doctor, then dietitian or physiotherapist or psychologist or all of them, followed by a nurse who will explain the drug, what has been prescribed. And further, we always try to make the prescription clutter free and minimum medicine, and explaining it properly when to take. So pharmacist, healthcare provider, all form of healthcare I have already mentioned. The summarizing the medication with their effect and side effect, as I already mentioned. For that, you will need to interact more with patient, which is usual practice, but we don't do. When you are spending time with a geriatric patient for 2 to 5 minutes in your busy clinical practice, then probably it's very difficult for you to explain the patient the drug, because that is the last thing to explain. You try to initially explain the disease, then for that disease you are prescribing drug, and you must prognosticate also the patient that this drug is going to help you this much and not this much. And of course, in prognostication, you are going to mention that if it is a neurodegenerative disorder, this is going to be progress, and if you don't take the drug, what is the problem? So here I will stop for a minute, and I'll say all of you to introspect when you are prescribing a patient, especially who is elderly. How many times you consider about his cognition? How many times you consider about his financial status? How many times you consider about hearing impairment? Is highly common. Hearing impairment is highly common. How many times you think that the caregiver who has brought the patient is probably a permanent caregiver? Many times it is not. Maybe a grandchildren, maybe son, maybe daughter-in-law. They hardly spend time at home with the elderly person, or in old age home or long-term care, some care manager, a single care manager is maybe managing 50 patients. It is practically impossible for him to remember whatever you have prescribed. So this is very, very important. You prescribe less elderly patient, but give him time, understand his mood, understand his cognition, understanding hearing capacity, understand his vision, understand his access to medication, understand his location wherever he is staying. All these matters a lot. So you have to chat with your patient for more time. You spend more times with elderly. Even in my this small experience of 2 decades with geriatric population, my 2 decades is exclusively for elderly people. I have not seen a single person who is less than 60 at least in my last 2 decades. So if you don't interact, you don't have time to interact with elderly, please don't be a geriatrician. You can practice with other client pool. So regarding technology, unfortunately, the digital literacy in elderly is also very low, not only in our country, even if you go through Western literature, digital literacy is a problem. It's a problem even in Western population, not only in India. And further, if you think of long-term care facility where people have been dumped, or who are just there to lead their last 1 or 2 decades of life, they are not very much interested to learn new things. So we have conducted a study again with WHO in long-term care in Delhi, we have seen around 40% patient has cognitive impairment, 50% patient has low mood, 35% patient has hearing impairment. So just consider in this three scenario, around 35% patient has immobility for some reason or other. So just imagine in this 3 or 4 scenario, if you don't have any support system, how the person is going to be adherent to medication. And simultaneously, as I mentioned, the role of doctors, I want to stress here what I try to practice in my day-to-day practice. I try to give the person OD drug, once daily drug. So once you know the half-life of the drug and give them the flexibility, I always ask, what time are you going to consume this drug? Is it in the morning or in the evening or after lunchtime? Whatever is convenient, we can give you for that time. And try to give once a day drug. You combine with multiple polypill, you combine, or you give them all drug in one shot. Even if there is some amount of I will say not contraindication, some drug interaction which will reduce the efficacy. Still, for considering drug adherence, you should give them medicine once a day. You can imagine once a day medication is even convenient for us who are comparatively young population. So reduce pill burden by using combination medication if possible, and an engaging caregiver is utmost important. So I first ask the person, and then I ask who is going to give you the medicine if he is not that active or intellectually that fit enough. So barrier, there are a few issues. I think most of the issues we have discussed. And so effective communication, which Sambhu and other speakers are also mentioning, is very, very important. For that, you have to spend time. Patient education. So we try to give leaflet also whenever giving them a, let's say, how to use the spacer. So once or twice the nurse will explain, but until you are not using spacer for your MDI, it is going to be very, very least effective for COPD or bronchial asthma that way. Similarly, medication management, regular monitoring, and collaboration with pharmacists if it is available. Like we have pharmacists, I don't know in all hospital has or not. Pharmacist here also educated, and they try to explain again. So we have 3-4 layer of explanation of the medication. First the doctor, then nurse, the pharmacist, and as I mentioned, the last person is the patient care coordinator. Even our physiotherapists are accustomed with the medication we write. If I'm writing ACE inhibitor, the physiotherapist will say, what time are you, ask this question, what time are you going to take this? Because after taking ACE inhibitor, you should not do aggressive physiotherapy. So that much oriented. So it is a teamwork. As we always discuss, the geriatric medicine is a teamwork. It is absolutely a teamwork. Here, no one is superior. Here, only hero is the patient, nobody else. Of course, cost of medication and physical barrier also matter. So I think I have only one more strategies to improve. Fewer dose, I have mentioned, utilizing medication organizer, some pill box, or any other things, you can use that. And involving patient in their treatment plans to enhance the ownership and responsibility. When I explain a person that, look, this is the antihypertensive I am giving you. This medication is going to reduce your blood pressure, especially systolic blood pressure. If I am giving a diuretics, then I am also explaining that, look, I am giving you diuretics, you will have more urine, so don't take this in night. If you are taking other medicine night, you have to take in the morning. But this is the side effect of the diuretics, so you have to follow your sodium level, and frequently you have to meet the doctor. So this much interaction, and the patient, then I again ask, do you feel that you will take this medicine? So if you are because what is my experience, senior citizens are very, very honest regarding this medication adherence. Mostly, I have seen also patient who say I take it, but every time he just throw the medicine, metformin, because of GI intolerance. But again, the point is, I hold responsible for that myself, that I have not explained him metformin has GI intolerance, and if you have GI intolerance, I have better drug to prescribe. So then, encouraging open communication between patient and healthcare provider. Our team is very strong there. It's not like any doctor-centric approach here. It's a patient-centric care, where patient and all healthcare family, along with the family member and the caregiver, are working for the patient, for his or her healthcare. So thank you. And this is my book on health and well-being in late life. You can just click. There is a Hindi version also has been recently published by NBT. I'm writing one more book on super aged that will come very soon. Thank you for the opportunity, and you can ask if I can answer any question.
Thank you, Dr. Prashan Chatterjee. Dr. Prashan Chatterjee has elaborated the matter very lucidly, and it explains that his experience is there. Out of his experience, he has deliberated the thing. He has touched every aspect of the adherence, I think. It's a very good deliberation.
Thank you, sir. Thank you.
Dr. Tripathi sir.
Yeah, of course, it is very lucidly explained, and otherwise it appears that these are very simple things. But again, truly speaking, these simple things tend to be overlooked in day-to-day in our day-to-day practice. So I think it is very important to learn or to listen from somebody who has gained so much of experience. As he said, that last 2 decades he is seeing all patients and communicating with them very closely. And he has very rightly pointed out that different strategies, particularly what he mentioned, these are very rewarding and engaging caregivers, he has said. So while prescribing for an elderly, the physician should keep that in mind, that who is the caregiver. And he has also mentioned about patient-centric care, which is very essential in case of the elderly care. So far as adherence is concerned, to explain in a very simple term, they say that medicines do not work if they are not taken. So as simple as that. So the primary precondition of medicine working is it has to be taken. But again, at the same time, I really appreciate when he says that before explaining that what good it can deliver, the medicine that is being prescribed, he also explains the side effects. That is a very good approach, that even after understanding or listening to the side effects, if they understand the patients, even after that, if they are convinced that they should take it, we should not take things for granted that we prescribe and they will take. It is said that many times the patient apply their own judgment, and finally they decide what they are supposed to do. So we should respect that, we should honor that and appreciate that. And Dr. Chatterjee has very uh, lucidly has explained many otherwise critical issues. We need to remember that elderly people are tend to be forgetful. They are many of the, particularly at further extreme old age, there is frailty. Fall is a as an issue, and then that fall, many a times that fall could be also induced by medicines. Many of the medications that the elderly people are likely to take, they also have anticholinergic effect which can impact on the cognition. We all know that there is an anticholinergic burden issue. So total anticholinergic score of the multiple medicines that the same person is trying to take. Immobility is an issue in some elderly people. Immobility, insomnia, incontinence, all these are also impacting and the decision making about prescribing and impacting on the adherence. Dr. Chatterjee also mentioned about the impairment, visual, auditory impairment, and cognitive impairment. Depression is also a factor in many elderly. Uh, so it was very lucid, quite comprehensive, and I think Dr. Chatterjee has done real justice to the topic in a very limited time. If there are some comments and questions, we can take. Dr. Shambhu, over to you. You can take the chat box, and if possible, we can also allow some of our participants, if they have questions, they can also directly put, if they can be unmuted. Over to Dr. Shambhu, if you are there.
Yeah, thank you, sir. So once again, thank you, Professor Prashun Chatterjee, sir, for this wonderful deliberation. And I think you had touched upon another area where you had also mentioned about cost. And I think in the elderly population, cost is something which is really concerning cost of their therapy. When we talk about adherence, that sometimes we again need to emphasize on some other A's, that is affordability and availability of the drugs. Many times this, and when we talk two of these affordability and availability together, then we check that metrics of access to medicine, so accessibility of drugs. So often we write drugs, newer brand names, and we found that that old man have to go to different pharmacies to get that particular brand due to unavailability of the brands. So I think this is again a very important area. And when we talk about adverse effects of drugs, we talk about lots of pharmacokinetic, pharmacodynamic interactions, those are related atrocities. But often we forget one important toxicity, and that is not typically pharmacological, but that is economic toxicity, financial toxicity to our elderly population. And that also, I think, impact a lot on the adherence issues for the elderly population. So I think you had elaborated this very well. And most importantly, you had mentioned about that NGO and this book, what I am seeing here, ensuring in adherence, our approach also, we told about education, how we can educate our patient, but that approach also should be empathetic. So often we lack that skill of empathy. And I think ensuring adherence, our skill should be, that blended with empathy. So one few questions I got in the message, and there are very important other question, and you had already discussed different aspects of those questions. I am just asking something like one of our postgraduate trainee from Assam Medical College, Dr. Snehashmeet Ghosh, he was telling us that healthcare for the elderly as a whole, how we should approach that. And here, when we talk about health, and when you ask our patient about their health related issues, how we should approach to other aspects of the health, like mental and social determinants of the health. How you feel that social determinants of the health, especially in the elderly population, is also very critical, and we need to ask some specific questions before choosing any therapeutics.
Yeah, see, the point is, Dr. Sambhu and Dr. Ghosh, that is the reason, when we talk about comprehensive geriatric assessment, it is not only assessing health alone. It has a social component, it has a psychological component, it has a mental health component, and finance is also equally important. So the point is, if you just imagine a situation when a person came to you, you saw, so that is the reason we say we do a person-centric approach. We don't treat the only disease, or we don't treat the organ it has been affected. See, for a 85 plus person who is a little bit forgetful or low mood, having a diabetes of 500, is it really matter to know that, oh, your diabetes is so high? If he said, doctor, I don't have anybody to talk to me, I am staying in the corner of my house, and people say, like in Hindi they say, buddha satiya gaya hai. Nobody talk to me. My son stays outside. My daughter-in-law doesn't speak to me, even if she stays here. And previously I could able to go to the nearby park, but now I have severe leg pain because of osteoarthritis knee, so I cannot walk down there. So just imagine for him, is it really matter whether his sugar is 500 or it is 200? So the social support, but the same person, if he is staying in a colony where the nearby peer group are motivating him to go to the park every day, interacting with them, doing some typical PNPC of the family, discussing about Modi and Mamta, he has some meaning in the life, like so the purpose. I'm fortunate that I am also WHO tag member for healthy aging in for the decade 2021 to 2024. I'm here. 2021 to 2030, WHO has declared as decade of healthy aging, UN. So there I listen to the people who are working in this field across the globe. We have around 20 such tag member across the globe. So everybody says do exercise, do dieting, have medication. But Sambhu, when an elderly person come to me and say, doctor, I don't know why should I wake up in the morning. So that is the patient or client whom you have to approach, whom you have to address. So in comprehensive geriatric assessment, we start with your socio-demographic profile, reading your address, your family member, your care provider, your financial status, uh, your support group, along with your cognition, your mood, your muscle. I call this as 4M: muscle, memory, movement, and mobility. So these are the things which if you don't approach, then probably your assessment is incomplete. So social domain definitely matters. I have published a questionnaire, which is a questionnaire-based assessment, ICT brief. This has been published in Indian Journal of Public Health. Indian Journal. So you can click in net, you'll get ICT brief 30 questionnaire we asked, which comprises of all the domain. So what I wanted to explain with this anecdote is social domain is equally important. When I visit my village, where my nani is there, my grandmother, mom's mom, she is extremely happy for 1 week, 2 week, whenever I'm there. But again, when I come back, she is not so happy. Then she every time say, I don't know why am I leaving? I should not survive anymore. Then again, my daughter, when she interact with her, so great grandparents, granny, again she revive little bit. So all this encompasses your so elderly life. If you make their life their only single home as their world, they will die very soon. If you make their life elaborate, societal support is stronger, then they will survive more.
Very
I
true.
hope I could able to address
Yeah.
your concern.
Yeah. Thank you, sir, for wonderfully explaining this. And I think this is a real story we always faced. And we also have, we can say, one of the very noted geriatrician from our city. We also, one thing I want to add with his designation, he is also a social geriatric practitioner. So welcome, Dr. Dhiresh Chaudhary. So you want to make some comment? Please unmute and give your comment.
Thanks everyone for this beautiful webinar. Actually, very time-needed webinar, and thanks to everyone also for their excellent deliberation. And already, Sir Dr. Chatterjee mentioned that geriatrics is actually the collaborative approach, and I am practicing geriatrics for it is nearly 2 decades. And already Dr. Shambhu already mentioned that my emphasis is on the social part, and which already explained nicely by Dr. Chatterjee that social part is how important in the geriatrics. Actually, if we like to talk on the adherence aspect, adherence is much more relevant in case of super aged elderly, much more, compared to younger old age. And another one is very important is when the geriatric patient is bed confined, bedridden patient. So nearly 8% of the total elderly population are bedridden. So if we like to address this section, when these geriatric peoples are totally dependent on the caregivers or the family members for giving their medication in the proper time and properly. So in that case, we need to actually we need to sensitize the family members and the caregivers much more. Otherwise, we cannot address this issue because if the adherence part, it depends on availability. Already you mentioned, Dr. Shambhu, that availability, affordability, these are a very important aspect. And if available also, like in the affluent society, the geriatric people I have seen, they are suffering from the medicational problem only because of unwillingness of family member, or the caregiver is not bothered at all how to provide a proper medication in the proper time. So this is very important issue when we like to address this broader aspect. And another, so in that case, is there any solution that audit of medication of individual geriatric patients at least once in a year or twice in a year? Is it any helpful? Is it any helpful, and or how can we audit? Actually, already Dr. Chatterjee mentioned there is a time-based practice. Geriatrics is a totally different because it needs a significant amount of time to deal with the geriatric patient, geriatric members, counsel them, even need to talk with the family members, caregivers, everyone. So, but rationally, it is not possible to provide so much time, especially in the chamber-based practice. So in that case, is it any helpful for auditing the medication yearly by any pharmacologist or the competent doctors, or the collaborative approach where we can include that? So is it any plans, sir, or your advice how to prevent that? And polypharmacy, as per definition, 5 or more than 5 drugs. But in my practice, I have seen 80 to 90% geriatric patients are more than 5 drugs. So 80 to 90% patients are already in the polypharmacy. So how can we prevent when it actually needed more drugs than five drugs, because more complications, more diseases are there? So this is my question and this is my input also, sir. Thank you very much.
So Dr. Dhires, Dr. Dhires. One is one you mentioned about auditing. Auditing. So you wanted to mention that people will go visit their home and door-to-door visit and then auditing, or see when we call the patient, when usually a doctor call the patient again for revisit. So doctor revisit or follow-up visit. So when you are following the patient, I think most of the doctor that I have seen in the practice, we invariably do that. First question we ask, जो दवाई हमने आपको दिया वो आप कंटिन्यू कर रहे हो कि नहीं. So usually my patient, what I do is they bring the empty things, empty packet, So because AIMS provide most of the medicine free. Most of the government institute provide them free. So even if you have purchased it, my usual practice is I ask them, show me the medicine you have consumed. So that is one way, of course. And secondly, every 3 monthly we call the patient for revisit. I don't know private practitioner how they are doing, but even a private practitioner also, I understand they call the patient back after 3 months. So invariably that is one form. But any other third party agency will do it. I don't know how much pragmatically it will be possible. Your second question was What was your second question? I'm sorry.
Polypharmacy.
Polypharmacy. Yes, it depends, again, your skill. So again, your skill related to your understanding about the life expectancy of the patient. Then number two, what is the patient's expectation from you? So if you ask me a single question, the commonest reason to visit a geriatrician by a 80 plus oldest old person is to improve the quality of life. It's not getting cured from diabetes, hypertension, coronary arteries, COPD, ONE. They come for improvement of their overall quality of life. So if that is the purpose, then I'm very happy. I'm very happy to reduce. You tell me the disease, I will tell you. I can restrict the medicine within 5 to 6 medicine. 5 or 6, 5 is not a magic number. Of course, we have to define, we have to put a ceiling. You are absolutely right. Mostly they get 80% times they get more than 5 medicine, because the problem is most of the doctor feels treating every symptom is going to appease the patient so that the patient again come back to him or her, which is absolutely wrong. More than 60% pantoprazole is wrongly prescribed, overprescribed, never should have been prescribed, or someone prescribed 10 years back for one episode of gastritis, and the patient is continuing for 10 years. Tell me one thing: 45 years age, someone had a cardiac arrest or CAD, coronary artery disease, went to hospital, angioplasty done, prescribed with 6 prophylactic drug for next 30 years to survive. So can you imagine that same 6 drug I should still continue even at the age of 80, when I understand his life expectancy is maximum 2 to 4 years. So you have to have that knowledge and understanding to tentatively, we cannot be very precise. I am working now on longevity study from ICMR. It has been publicized a little bit also, where I am working. We are seeing 20 biomarker from 12 hallmark of aging. Maybe in future we'll come up with your biological aging, or maybe your speed of aging, your life expectancy. But still, if someone has multimorbidity, the person you are discussing, Dheeraj, the person who is consuming more than 5 drugs means he has multimorbidity, right? Multimorbidity or geriatric syndrome. His chance of crossing 85 is very, very minimal. And if that is the case, I will definitely not continue statin in the same dose what has been prescribed at the age of 45. I have patient who is 90 plus with 160 LDL with 40% carotid artery stenosis. You understand? With hypertension, with diabetes, I simply stop their statin with after explaining the side effect and the effect of statin, because at the age of 85 or 90, their sarcopenia will be invariable until unless you are exercising every day throughout your life.
Yeah, very rightly said. I just can compliment here that so far as polypharmacy is concerned, the definition that mostly we find is 5 or more medicines. But how do you define a medicine? Are you really meaning a particular molecule or a single ingredient product, or any formulation you are calling it medicine? Many times when you say 5, actually it is not 5. They are getting 5 formulations, but each of these 5 formulations are fixed dose combinations of 2 or 3. So practically it becomes 12 or 13. So the definition of polypharmacy is also problematic. The more the number of medicines, the more is the chance of the adverse experiences. So I fully agree with Dr. Chatterjee that we need to understand the treatment goal. What is the treatment goal and what you are trying to achieve? I think that very rightly said. The other issue Dr. Dhiresh mentioned about the what was the other issue about
Audit.
audit. So I think it's a very important area. In fact, truly speaking, the geriatricians, if they are actually doing geriatric practice, they are possibly expected to do a holistic approach towards the elderly health, because the same old man, he has been prescribed by 5 different specialists, organ specific specialist or system specific specialist, whether cardiologist, neurologist, gastroenterologist, etc. But then when he lands up to a geriatric practitioner, it is expected that the geriatrician will take a holistic view from the patient's perspective, understanding what is best for the elderly man's health and his life expectancy, and accordingly try to justify, trying to de-prescribe as much as possible without compromising the too much of the treatment goals. If there are redundancy, to cut short the redundancies. And yes, there are not too many geriatricians at the present moment in the whole country as opposed to the number of elderly people. The other kind of audit or other kind of thing is what Dr. Shambhu was mentioning, that we had tried to develop a model of that clinical pharmacological reconciliation review and feedback, so CPRRF model. But then again, possibly we don't have enough pharmacologists doing pharmacological practice. This, if we can call this a pharmacological audit, we don't have that many. And to talk of clinical pharmacologists, they are also very few in this thing. Dr. Chatterjee has also mentioned in their center or in an institute like Olney Institute, you can afford to have a team of clinical pharmacists, but they are also very rare species in our broad healthcare system. Excepting for institutional healthcare delivery, you don't find practicing clinical pharmacists in this country. But then when it boils down to geriatric practice, yes, this is our expectation from the geriatric practitioner, that they will take a holistic view of the patient's perspective and do what is best in terms of the patient's health expectations and health goals. That's it. Thank you.
Sir, can I say one line?
Yes, sir. Yes, sir.
So with the geriatrician, if we keep in view the focus of geriatric care,
right,
those are the care, not cure, functionality, independence, and prevention of iatrogenesis. That if we keep these four things in view, then the problem may lessen.
Very nicely said, sir. Particularly the last one, prevention of iatrogenesis. Okay, that is very important. Yes. Thank you, sir.
One third of the hospitalized patients are from due to iatrogenesis.
Right.
Thank you, Dr. Tripathi sir and Dr. Chatterjee and Dr. Dash, all of you. Nicely, you explained that. But you, Dr. Tripathi sir, you have mentioned the holistic approach, and in holistic approach, we always prefer whoever practicing geriatrics. But in case of Dr. Chatterjee, what mentioned that the statin, regarding the statin,
right,
we are actually there is a fearness from our side. If we even understand from the fear, we cannot reduce or we cannot stop that, because if the other doctors are in the not same mind or they are not aware about the holistic approach, then some confusion arises, because from our aspect, from physician aspect, the other doctor will may confuse the patient that, oh, why that doctor reduce the dose, that may be harmful. So then
Dr. Dhiresh, let me intervene. It is here where the importance of communication. You need to talk with the patient. What he wants. I can advise him. Yes, you are always welcome to visit 5 different specialists. But then at the end of the day, what are your expectations? What Dr. Chatterjee also has very nicely mentioned. Okay, what are the treatment goals? What are the health goals? What are the health expectations? What is the age of the patient? If he is really at a very old age, then he has already, truly speaking, average life expectancy, he has already lived his life, and he is now the extra lease of life he is surviving. There, it is important what Dr. Chatterjee said. It possibly is not very important to have a very strict, stringent glycemic control there. While the 2 or 3 different anti-diabetic drug, that is also creating another series of drug-induced problems. So I think it is, the more you develop mutual trust or have mutual confidence, if the patient can be convinced and the patient is taken into confidence, then possibly these kind of fear or these kind of the possibility that they will again go to his cardiologist, the cardiologist will say why this has been done by the geriatrician or some other practitioner. This is not going to happen. Unfortunately, many a times we are trying to avoid medical legal issues. we are not doing possibly justice to our patients.
Actually, I'll just add one more point here is, recently this happens actually, a very, very VVIP patient got admitted who is 90 plus. And the example, the story I told was his story. So along with me, there was cardiologist also, because AIMS has every specialty. So I put the ball in his court and say that this is sarcopenia, this is his muscle mass, this is his muscle strength. He can't even take few steps himself without any support system. He has 40-45% carotid artery stenosis. He has moderate mitral regurgitation. Okay. And he has LDL of 140. So I understand that you'll be happy to prescribe statin, but this is my logic to say that statin will cause myopathy and sarcopenia will further facilitate. And I understand, not in front of the patient after that, the story that his life expectancy is not more than 1 year. Now, what do you suggest? So the communication is so very important. And as I mentioned you, we need not to be hero in front of patient. The point is, if you can keep aside your ego, automatically the specialist, super specialist, whoever is there, and if you humbly submit your knowledge in front of the doctor along for the patient, which is ultimately going to benefit the patient, then the decision is totally from the patient. So you'll be surprised to know he convinced that, and he himself went back to the patient and explained, sorry, it was my mistake. I thought I'll start statin, but what Dr. Chatterjee is telling is much more scientific considering his present functional status. So this is the thing again, it all depends your understanding, patient's understanding about you, patient's goal, what Dr. Tripathi is also rightly mentioning.
Thank you, sir. Just one line to add. Generally, when also we do clinical pharmacological reconciliation review feedback, we need to remember one mantra to give emphasis on poems rather than DOEs. Now, what is the full form of DOEs? Disease-oriented evidences. So do not rely only on those disease-oriented evidences. Rather, we need to emphasize on poems. That means patient-oriented evidences that matters. So our decision should be very much personalized. And when we talk about elderly care, it is we should very stringently follow this rule. I think that can overcome many barriers also. So thank you, Professor Prashun Chatterjee. I think now I am requesting a very important part of today's meeting, because when we are discussing about adherence, if we have some supporting devices which can ensure adherence, so rather may I request
Dr. Sambu, I'm sorry if you can leave me, because I eat daily once, and I'm extremely hungry, and usually I eat once. I don't take lunch, so I'm on a time restricted feeding. So I have to move, and I have already met Rohan. So Rohan can meet me anytime. I think we met each other in some Bayrak DS.
Right.
Yeah. So I'll definitely meet you, Rohan. So be in touch, and I have shared my mail ID with all of you. Many of the name I am seeing, I have seen their name in LinkedIn. So any question, any support from my side, please let me know. I'll be always happy to share. Okay. Thank you.
Thank you, Dr. Chatterjee, for being with us.
Thank you, sir. Thank you all. Yeah, and if you come to Delhi, please come to National Center.
We'll
Thank
come.
you. Thank you, sir. Thank you.
Bye.
So now may I request Mr. Rohan Tripathi to please showcase that device and how we can address the issue of adherence. To please carry on.
How much time you are giving to Rohan? How much time?
Now stage is yours, Mr. Rohan Tripathi. You can start.
Hello. Is it visible?
Yes.
Okay. Thank you so much. I will not take too much time. I will, because it was a very amazing.
Just to interrupt, please take your time, because this is one of the another important part of today's meeting. So we also need to learn about this device in details. because this is again an very important part of today's meeting. So please
Yes,
be
yes.
easy, and you have to explain this because we have many delegates who also want to learn this, how they can be benefited for their patient care. So please take your time, please be slow, and please explain in details. And I think you also have one question in your that chat box that has been asked by Dr. Shukollan Shaharoy. You please check that question. He is a professor at IGIMS Patna. A very important question regarding your device. So if you, at the end, you please try to answer that question, and please take time and explain. Over to you. Thank you.
Sure. Thank you so much. So it was very wonderful hearing from sir, and then hearing the entire discussion that was being done. So here at iNovocare Health Hub Solutions, that's our institution, what we are primarily focusing on is a part of medication adherence. We are typically focusing on the forgetfulness issue. We are having to, that is the principal aim part of medication adherence that we are focusing on. And any kind of presentation on this can't start or end or begin without this quote from the great man that I think this quote has already been repeated in this evening, but still I will go on. Drugs won't work in patients who don't take them. So many years back, when we first started with this problem, at that time, we were only looking at the US data. We were looking at the thing from this could be needed in USA or in the first world country, or like where it's the per capita income is much higher, that kind of problem. But when we year and after a lot of data collection, meeting a lot of people, we spent a lot of time in the School of Tropical Medicine under Professor Shantanu Kumar Tripathi, and also with Dr. Shambho Shamrat Shomazdar, who has been our mentor from day zero. And we had encounters, we had lovely meetings, discussions with a lot of people. So after all this, we understood the main parts of the problem. One, the parts were remembering when to take medicine, fear of overdoses or underdoses, fear of the anxiety that comes with it, maintaining the stock of pills, and also not being able to recollect the consumption. I was so as we were hearing the previous talk, the things that repeatedly were coming up is the cognitive impairment, the lack of ability to learn new things, the anxiety involved with it, and the dependency on the caregiver, who might not always be the best trained person or the person who is feeling more heartily about the person they are caring, they are scheduled to care for, or they're actually caring for. And a lot of times in India, still human intervention is relatively not that costly, but still, if there was a affordable technological intervention over a span of time, it is always more affordable than a human intervention. And another part that I will slowly come into that was being repeated previously on medication auditing. Like sir told that in their setup, he asked people to bring the packets of the medicines or the empty blister pack. But it might happen that the person who is again scared of being scolded for not having the medicine, just before the visit, is taking out of the medicines from the blister pack and then going. Like, is there any way or tool to stop that? Now there is. So one thing it is established, we can't ensure corporal punishments like this to ensure people are remembering or having their medicines on time. And when we did a lot of research on the existing devices, there were two sides of the spectrum. There were some typical things that were found, like your Monday, Tuesday, Wednesday, Thursday, that 7x3, 7x4 boxes, your envelopes on which times of the medications were written, which absolutely lack any proper system of vigilance to the adherence that was happening. Also, in a hot and humid country like India, it's not at all suggested, and I don't believe any medical association would approve keeping different kinds of medications naked out of the pack in a same spot over a long time, in a same container over a long time, when it is out of the blister pack protection. That was one side of the, and what was happening, the people were writing the timings on the envelope. But what happens was, suppose you have two envelopes, on one you have written 1 a.m., on one you have written 9 a.m. So after eating, due to the not so much highly training of the caregiver, they are getting mixed. And the medicine that you need to have before your lunch at empty stomach, you are having after your dinner on a fixed stomach, full stomach. And on the other side of the spectrum, there were some state-of-the-art devices using machine learning, AI, and everything. But in a country like India, expecting people to spend so much, like to the north of few lakhs on a medication on a medication dispensing unit that again requires 24-hour Wi-Fi, that was too much of ours that we found when we went around. So after a very long and tedious research and development process through a lot of iterations, where we also had a extended session for medication adherence awareness, a year-long program. This is soon to be published as a book. We arrived at MedpeR. It's called MedpeR, or Medicinal Helper. So what is it that we are focusing on? Effortless organization, technology integration, user-friendly interface. Because one of the problems is that it's difficult for the elderly person to make them learn something new. So what if it was something they're used to? If I ask them to learn a new software or a new app, they say, "Na babu parbo na, ami ki kore korbo," or "It's so difficult. How will I learn a new thing?" But if I give them a simple box like this, hey now, oshudar baksho, when it's time, alo জ্বলবে, শব্দ হবে, ডালাটা খুলে খেয়ে নেবে. Just light will be there, sound will be there. Open the packet, take it out, have the medicine, put it back. As simple as that. You do not need 24-hour Wi-Fi. You do not need to learn a new app or software. So this is how it is. So this is my device. It's MedpeR. So you can see when it's time to have the medicine, there is dedicated light and sound alert, and this does not need any Wi-Fi to operate. So if there is Wi-Fi, we have the push notification. Suppose someone sitting in Mumbai or Mauritius can check their mother or father in Kolkata is having the medicine on time or not, and the entire consumption journey is tracked. Another typical issue is when refilling, people make a common human mistake, and for that what is happened, the entire mistake is repeated as long as the strip or the dose lasts. And Dr. Shamazdar, he also had a case where a 60-plus-year-old woman was having double the amount of metformin due to this, or sorry, half the amount, and that led to diabetic coma, and finally death. I think he would be able to recall that. So that was one of the cases where the issue or the silent killer, that was the human error during refilling. So also we have a adherence report, because another part that was we were talking about before, medication audit. So what if it is very difficult in this day and time to assign a doctor behind this job? What if you do not need a doctor for this? At the end of the day, a medically trained person can just see if it is being consumed on properly or not. Sure, there are certain aspects like when there are ADRs, when there are drug-drug interactions, when something is happening, then definitely a doctor is required for this audit. But just to see whether the person is forgetting or not, or having or not, I don't think we need to eat up our doctor's valuable time for that. Another thing is there is a ergonomic design. We have 8 large compartments because we were talking about the reliance on up to 5 or more than 5 medicines. Our mentors told that for a person who is otherwise not needing critical care, there we can assume that the person should have around 5 medications at the max. So 5 to 8 we thought, but was a safe space. So there are large compartments that allow you to put the medication in along with the blister pack protection. There is also one slot. It is marked as the infinity box. So there is for the emergency medication. Suppose you are solvent sick or something like that. It is portable. There is a long battery life, and you can just keep it in charge. But once full charge, it can run easily for 4 to 5 days. And you can easily share the medication adherence report, and you can assign different roles. Suppose a caregiver or a person who is in charge of a multiple patients, they can access and view the condition. So this is us. We have just recently launched. So these are the features that we are having: effortless organization, smart medication reminders, enabling you to stay updated and stay without anxiety. So it's absolutely portable, light, less than around 750 grams, does not require a constant Wi-Fi or smartphone, user-friendly user interface. There's emergency medication, there's a pocket for that, long-lasting battery life. And this is one part I would also mention. When you're having a clinical trial or when you are part of a service provider, where you need to take care of not one, because an example came up previously, even in old age home, suppose there is one caregiver after 50 or 100 patients. So it's not possible for that person to remember or to check each medication they're having. And due to the typical lack of training there, medication adherence errors are happening, and the bigger issue is that repeated medication adherence errors are happening. Because typically, see, when the person is not trained, if there is one mistake that has been occurred, the ability to check that and correct it, it's not there. So if there is one mistake that has occurred once, until the entire medication pack runs out, that mistake will be repeated. So that is why we are having a system now. If someone wants to use it, they can just on one screen see many the 10 to 100 users who are under that caregiver's care. They can just check whether it's going on all right, whether something has been missed, whether it is being taken, the entire thing. So as Dr. Chatterjee sir, he was saying that do you expect him to go to the patient and ask? That is very difficult. That can't be expected. But it's the same thing when it is ready on one single screen. You can just scroll down and see if a flag was raised. If it is raised, there's an issue. Just call the person and check it. So that is what we are offering. So we are proud to have been featured in 2 books as of now. One more book we are featured that is going to come out soon. We were part of the prestigious Assistive Technology Development Program by the NISH, that's in Kerala. We were also part of the prestigious Stanford Seed Spark Program, enabling the development of innovation by Stanford Graduate Business School. And a few months back, we were proud to have met Professor Cecilia, who is from the Department of Global Public Health at the Karolinska University, Sweden, who saw MedpeR, that is our smart pill box, and appreciated it. And very recently, we have been launched. We are commercial right now. We are taking MedpeR here and there everywhere because we want the message to reach to as many people as possible. recently we were at the Indian Pharmaceutical Congress, where it received a lot of appreciation. So this is my team. I'm Rohan Tripathi. I have Indrajit Mukherjee, Kuntal Roy, and Gaurav Shastra with me. We have our mentors, Dr. Shamas Das, and our senior mentors, Dr. Abhijit Hazra and Dr. Sushil Chobe sir, whom we are deeply in debt to for continuing their guiding support and nurturing care from absolute day zero. So what the main aim behind today's the event today and our presentation here was to request the doctors, the healthcare providers, and the decision makers to help us, allow us to integrate the digital tools like MedpeR or other tools into that process, because our government is working behind the digital health mission. So unless there are these new age digital tools are coming up, like Dr. Dhiresh Chaudhary sir told, like that even for people for whom affording is not an issue, but then who will be there to remind them? Because son or daughter is busy, caregiver has been assigned, but after all, he is only a human. He will be very attentive for the first 7 days. Then we will like, okay, thik ache, diye diyechi. But if you leave it to a system that is developed and that is completely trustable, then you just not need to worry about it anymore. It will automatically be happening. So that's the dream that very soon when we ask ChatGPT how to ensure my mother has all her medicines on time, ChatGPT will say just give her a MedpeR. So we would be happy to have a demonstration, physical if it's in Kolkata and virtual if it's outside, to show MedpeR in even more greater detail to any of you. Currently we are available on JioMart, 1mg and Flipkart, soon to be available on Amazon. And these are our contact details. We'll be happy to connect. And if there are any questions, I would be very happy to answer them. Thank you.
Oh, thank you, Rohan. Thank you,
so
Rohan. You have described your device elaborately. One point I have come to my mind that if you attend the conferences by the of giving stalls, there will be hand-on training of that person. It is required probably. Kindly think over it.
Absolutely, sir.
Very nicely presented.
If we are allowed and well,
But the conference organizer will not give you free chance. But wherever I shall go outside for the Eastern zone, I can provide you some space. But in West Bengal, I cannot assure you what they will do. You can approach them. If they give you any concession